Inside Los Angeles County General Hospital, why it was abandoned. For decades, Los Angeles County General Hospital was the backbone of public health care in this city. So how did a hospital this important end up empty and forgotten? To understand how this happened, we need to start at the beginning, when the hospital was first created. The Los Angeles County General Hospital was founded in 1878 as a modest 100-bed facility on Mission Road. It came about because the county wanted to cut costs from relying on private hospitals like St. Vincent's for caring for the poor. At the time, Los Angeles was growing rapidly in the late 19th century, with waves of immigrants and economic ups and downs leaving many without access to medical care. This hospital was built to address that gap, providing essential, no-cost treatment for the acutely ill and suffering, as mandated by state welfare laws for counties to support the indigent. It served the uninsured, the poor, immigrants, and those facing trauma or sudden illness, ensuring no one was denied care due to lack of means. That principle was even carved in its cornerstone in 1930. From the start, it affiliated with the University of Southern California's medical school in 1885, turning it into a teaching site as well. The iconic Art Deco building that most remember opened in 1933, solidifying its role as a public commitment to health for all. In short, this place existed to deliver vital medical services to the county's most vulnerable residents in a city that was expanding fast. The hospital hit its stride from the 1930s through the 1960s, after the new 1,680-bed facility opened in December 1933. It became one of the largest public hospitals in the country, handling hundreds of thousands of patients each year, far outpacing many private institutions in inpatient days. During these busiest decades, it managed everything from everyday acute care to major public health challenges like infectious disease outbreaks amid population surges. Departments focused on trauma, emergency services, infectious disease control, and a large psychiatric unit kept operations running around the clock. As a teaching hospital tied to USC's Keck School of Medicine, it trained generations of doctors, nurses through its own College of Nursing started in 1895, and other health professionals. This role advanced medical education and helped the city respond to crises, from wartime injuries to epidemics. County health reports and newspaper accounts from the era show just how massive its scale was, serving as the go-to for comprehensive care in a booming metropolis. This place really mattered as a machine keeping the city alive through its sheer function and reach. Communities across East Los Angeles, Boyle Heights, and the wider county depended on it deeply. It was the main safety net provider for over 10 million residents, especially low-income families, immigrants, and Latinos who made up more than 70% of patients in later years. Two-thirds of its caseload were the uninsured, who turned to it for everything from primary care to specialized treatments without fear of bills they couldn't pay. In emergencies, it was indispensable during events like the 1965 Watts riots, natural disasters, and everyday crises, handling 28% of the region's trauma cases. For many, alternatives were scarce. Private hospitals often turned away those without insurance, leaving this as the only option for births, chronic conditions, or urgent interventions. County archives highlight how generations built trust in it as a reliable public resource. But systems like this don't fail all at once. The strains built gradually, starting with funding pressures after Proposition 13 passed in 1978, which cut property tax revenues and squeezed county budgets. This led to ongoing crises in the 1980s and 1990s as Medi-Cal payments dropped with shifts to managed care models. Overcrowding worsened as the uninsured population climbed to 2.7 million non-elderly adults by 1992, stretching wait times and resources thin. The building itself, aging since its 1933 opening, faced mounting maintenance issues, culminating in damage from the 1994 Northridge earthquake that exposed seismic vulnerabilities and triggered new safety standards. Retrofitting would have cost fortunes the county couldn't spare amid these shortfalls. Policy changes added to the burden. State reforms to Medi-Cal and federal cuts in the 1990s pushed healthcare towards privatization and decentralized networks, reducing revenues for big public hospitals like this one. These weren't isolated problems, but interconnected. Public funding dried up, patient loads swelled, infrastructure decayed, and operational efficiencies suffered. Maintaining it became increasingly difficult because the system was evolving away from such centralized models, making the old setup unsustainable. Put simply, funding cuts, overcrowding, and aging infrastructure combined with broader policy shifts to create an inevitable strain. Services started reducing after the 1994 earthquake forced closures of parts like the psychiatric unit. Inpatient operations fully ended on November 7, 2008, as the building no longer met modern seismic codes. Patients were redirected to the new LA plus USC Medical Center next door, a 600-bed facility built in phases from 2008 to 2010, funded by state money and federal earthquake aid. This replacement took over the roles, merging and decentralizing care into safer, updated structures to ensure services continued without major disruptions. By then, the timeline was clear. Operations wound down methodically as a new era took hold. Today, the original building stands under Los Angeles County ownership, mostly vacant. Lower floors have been repurposed for things like a wellness center and administrative offices, but the upper levels remain unused due to ongoing seismic risks and the high costs of full retrofits. Access is restricted, and while it's not completely abandoned, it sits idle because adapting such a massive structure safely isn't straightforward. Current plans point towards reuse as mixed-income housing, up to 885 units, along with medical offices and retail in a Healthy Village project, with environmental work underway to make that possible. Yet this isn't just about one building. It's part of larger shifts in how we handle public health. The hospital's story mirrors the evolution of American public health care, from expansive, centralized county institutions focused on indigent care to more decentralized, privatized systems. Newer models brought gains like seismically safe facilities, integrated networks, and efficiencies through managed care, reducing some strains on single sites and improving access in scattered clinics. But with that came potential losses. The closure of these big hubs may have diluted the concentrated expertise and community trust built over decades, leaving gaps for the most vulnerable in a fragmented landscape. It raises questions about balancing cost, safety, and equity in how we provide care today. In the end, places like this remind us how public health adapts to changing times. If you're interested in the history of places like this, you'll find more stories on the channel.